much, and thank you very much for inviting me here. I didn't have a chance to have my workout this morning, so I'm going to see if I can do what Dr. Lizzie did and look into the talk that I'm giving, and I'm kind of hoping that it will also solve my inchopenia. We'll have to see. So I have no conflicts of interest. I am going to cover a few topics for you today. First of all, I'm going to talk a little bit, give you a definition, a little bit about the epidemiology of cancer survivorship, an overview of cancer-related healthcare needs of cancer survivors, and an overview of the general medical and preventive healthcare needs of cancer survivorship, and finish with a discussion about the role of primary care practitioners, since this is a group of predominantly primary care practitioners, in survivorship care, and something about survivorship care plans. So first, in terms of the definition in epidemiology, there are two dominant definitions that have been used. One of them is talking about cancer survivorship as cancer survivors being at any point subsequent to the diagnosis of cancer. The other, which is the one that's used in the book, which I highly recommend to you, the IOM report, From Cancer Patient to Cancer Survivor, Loss and Transition, defines it more narrowly as the period following first diagnosis and treatment, so after treatment is over and before the development of recurrence or death. So schematically, this fits into a very defined range where treatment is over, there is no indication of recurrence, and other words that we use for this period are the follow-up period or the well follow-up period. So I just want to emphasize that that is the definition of survivorship that I'm using in this talk today. So, so that we're very clear that we're talking about a very, very specific interval in the trajectory of cancer care. Now, when do people become interested in cancer survivorship? Because really the focus of cancer research has been survival. And that's where we usually put all of our energies and all of our concerns. And then really following from the 2006 report from the Institute of Medicine, there's been really a growing interest in and awareness of survivorship as a different concept from survival in cancer. And part of that relates to the epidemiology. Because really, epidemiologically, what we're seeing is that there's an increase in the prevalence of cancer survivors. It's estimated that in the US, there are 12 million individuals with a history of cancer, according to the way in which I've defined it. And that's it's an international issue. So on the one hand, it's a recognition that there are a different set of concerns and needs for cancer survivors. And in terms of the health services perspective, there actually is a real demand on healthcare services as the increase in the prevalence of cancers. And I do want to emphasize that the increase in prevalence is a combination of earlier diagnosis and improved treatments, as well as an aging population. So cancer is a disease of the elderly. So the aging population means that we have a larger number of individuals being diagnosed with cancer, and many of them will survive longer with their cancer because it's diagnosed earlier and treatments have improved. So that's kind of what's behind the epidemiology. And I'm going to show you two graphs, because the talk today I'm going to focus on breast cancer and colorectal cancer. And I'd like to remind everybody, we so focus on breast cancer, but I do want to remind everybody that half of individuals with colorectal cancer are women as well. So we need to pay attention to that. So this is a graph which shows conditional relative survival. And what it shows you is that the earlier the diagnosis, early stage of diagnosis, survival is very, very high. So anybody diagnosed with stage 1 has over a 90% likelihood of being a long-term survivor. Stage 2 is a little bit lower, and stage 3, again, is a little bit lower. But nevertheless, for breast cancer patients, on balance, given the stage of diagnosis at the population level, over 80% will be long-term survivors. The conditional part of this graph, if you note, it says And if you're at the point where you're 5 years from diagnosis, so you've already survived 2 5 years, if you've already survived, your point of diagnosis is here. So at that point, what's your 5-year prognosis? But the longer you survive, the more your prognosis improves. So that's the conditional component of this graph. Similarly, for colorectal cancer, we see a same sort of phenomena. Unfortunately, for colorectal cancer on a population basis, because it tends to be diagnosed as a later stage, the overall population, there's a 60% likelihood that individuals will survive. But hopefully, with the spread of colorectal cancer screening programs, that earlier diagnosis of colorectal cancer, we will soon also be seeing the majority of individuals surviving, 80% of individuals surviving, being long-term survivors. So in summary, 50% of cancer patients, on balance, all cancer types taken together, will be long-term survivors. When it comes to breast and colorectal cancer, these are the most prevalent cancers in the population. 80% of breast cancer patients will be long-term survivors. 60% of colorectal cancer patients will be long-term survivors. And it's estimated that about 3% of the population are cancer survivors. Most are elderly, as I will show you, most are elderly and have other multiple comorbid conditions. So quickly to give you an overview of what are the cancer-related healthcare needs of cancer survivors. So here's your patient. She's a woman, a 48-year-old woman with breast cancer. She had a T2, N1 meaning that the lymph nodes were involved, M0 means that she doesn't have metastatic disease. Carcinoma of the left breast. Her primary treatment consisted of a lumpectomy, breast-conserving surgery, chemotherapy, and radiotherapy. And she's now on extended adjuvant treatment with an aromatase inhibitor. So the question is, now what? Her oncologist recommends that for follow-up, she should have a visit every 3 to 4 months for 10 years, an annual CAT scan and bone scan, liver function tests and blood counts each visit, tumor markers at each visit, bilateral mammograms every 2 years. Do you agree with that? So hopefully by the end of this talk you won't. So for survivorship, what are the survivorship issues? Routine follow-up care the focus of that is to detect recurrence of the cancer, to look for late effects of cancer and the treatment that the individual received, to look for new primary cancer is very important. The highest risk factor for breast cancer, other than being a woman, is having had a previous breast cancer. So you really, really need to be vigilant about diagnosing a new primary cancer. The earlier the new primary cancer is diagnosed, the better the prognosis. So the fact that if somebody has a stage 1 cancer and a second cancer that's a stage 3, then their prognosis is determined by the stage of the second cancer. Obviously, psychosocial issues that have been very extensively studied and documented related to cancer, and special issues depending on the cancer type and the individual factors for the patient. But in addition to that, the survivorship issues are related to general medical and preventive care. So some of the special issues are ongoing adjuvant hormonal therapy, and I will say a word about that, weight control, lymphedema, menopausal symptoms, osteoporosis, cognitive functioning. There's believed to be a relationship between higher level executive functioning and having received chemotherapy. There's a question of whether there's a relationship between that and aromatase inhibitors. Some of this is not yet fully understood or described, and psychosocial issues. So with respect to detection of recurrence, the vast majority of recurrences will occur within the first 5 years. And that is the case for breast cancer and most other cancers. But one thing that's unique about breast cancer is that recurrences can occur even up to, for the first appearance of recurrence, can be even up to 10 years after diagnosis. So one does have to be a little bit more mindful. The most likely time is in that first 5-year period, but it can occur at any time. The most frequent sites of recurrence are a local recurrence within the breast, bone metastases, liver, and lung. Those are the most frequent sites. The other interesting thing about recurrence, although the purpose, the ostensible purpose of routine follow-up, which primarily takes place in oncology centers, is to detect recurrence, actually, what we realized is that the majority of recurrences are detected at interval visits, and they're detected by the patient herself presenting with a sign or symptom related to recurrence, and a large proportion of cases she presents first to her primary care physician. So that we now see, and this is a kind of a summary of some of the descriptive studies, although with respect to this study here, it was within the context of a randomized controlled trial, we now see that in fact it's the primary care physician who is the individual who's diagnosing recurrence. Now, adjuvant hormonal treatment is, it's widely recommended, widely used. You probably have many patients, your breast cancer patients, who are on adjuvant hormonal therapy. And there is a sort of complex mix of treatment scenarios, which I'm just going to give you a very broad summary of, but I will direct you to the American Society of Clinical Oncology guideline, which is, the first author is Burstein, and it was published in the Journal of Clinical Oncology in 2010, which gives the recommendations with respect to extended hormonal therapy. But there are several different scenarios. One of them is tamoxifen, starting with tamoxifen and taking it for a maximum of 5 years. Another is starting immediately with an aromatase inhibitors and taking that for another 5 years. Important thing here, a maximum of 5 years of tamoxifen, a maximum of 5 years of an aromatase inhibitor. There is another scenario for aromatase inhibitors that you start with one, and after 2 or 3 years you switch, or you started after 5 years of tamoxifen. As I said, an aromatase inhibitor that switched after 2 or 3 years on an aromatase inhibitor. So there are different scenarios, and it may be complex to realize precisely what scenario your patient is on. So that's where you go to the note that you received from your oncologist, hopefully you will have received it. But one thing to bear in mind is that if you have a patient who's no longer in contact with an oncologist, and she is on tamoxifen, it's probably worth having her have another consultation to be assessed as to whether or not an aromatase inhibitor is indicated for her. One thing about aromatase inhibitors, only for postmenopausal women, so it is contraindicated for anybody who is peri or premenopausal. There is a particular concern with respect to the loss of bone mineral density, as Dr. Lindsay pointed out, and the fracture rates are about 2 to 4% per year. There's also a side effect of bone and joint pain. So there is a significant proportion of people who do not tolerate it because of bone or joint pain, and there's also a concern about lack of adherence related to those kinds of side effects. But certainly, if somebody is on an aromatase inhibitor and has this osteopenia word, you should be very concerned about it and monitor the bone density. And if she becomes osteoporotic, then certainly treat accordingly. For tamoxifen, it's been the standard of care for many years. There are major meta-analyses that have shown that it really is the standard of care. It is a minimum of tamoxifen, and it can be given in the pre, peri, or post-menopausal range. We all know that there's a small but known risk of uterine cancer. Hot flashes are one of the significant side effects, as well as thromboembolic events. So the ASCO guidelines with respect to follow-up of breast cancer patients every 3 to 6 months for years 1 to 3, no evidence behind that. It seems like a reasonable thing to do. Every 6 to 12 months for the following till 5 years. That's that 5-year windows because that's the most likely time for recurrence. Annually thereafter, annual mammogram. The most important test for an individual with breast cancer is having a mammogram every year. Both to detect for local recurrence if she's had breast-conserving surgery and to detect for a new contralateral primary. No other investigations are recommended. So no routine imaging investigations for metastatic disease, no routine blood work, no tumor markers. The reason for this is because there are 2 randomized controlled trials that have really shown that earlier diagnosis of recurrence does not improve survival. So for breast cancer, the recommendation is quite clear that there is no benefit in doing routine investigations because detecting the recurrence, the distant recurrence early, will not improve survival. So then, I'll just pass over this because I've already covered this information, and this just summarizes for you some of the prevalence of latent toxicity. It's very difficult to measure prevalence, but certainly premature menopause, things related to hot flashes, things related to lymphedema, these are quite prevalent, but you've got it in your handouts. I would like to also make a pitch for exercise and weight control because I think that the evidence is really growing about the benefits of regular exercise and weight maintenance. So this slide, this graph is from it is published in the Cancer Patient to Cancer Survivor book that I mentioned, and it comes from the Nurses' Health Study, which is a longitudinal cohort study. And what it found is that within that cohort, for those people who had breast cancer, if they were sedentary, which was to be doing less than the metabolic equivalent, so if they were sedentary, then they are more likely to be experiencing a recurrence of breast cancer mortality, and all-cause mortality. So this 9 here is roughly equivalent to what's recommended, which is 30 minutes, 150 minutes a week. And you can see that the risk of each one of those events is reduced if the person is active within that range. It seems to go up if they're overly active. But within that range, their risk of breast cancer recurrence, breast cancer-related mortality, all-cause mortality is reduced. So I think that that's a very, very powerful message. And similarly, looking at the other side of the coin, those individuals who gain more weight are more likely to have those events, more likely to have recurrence, breast cancer mortality, or all-cause mortality. We can see here that the 1.5 level, the 0.5 level for BMI, which can be as little as 3 pounds, a weight gain of 3 pounds, depending on the size of the individual. So I think 2 important messages for cancer survivors in general, which fits into all the other chronic disease messages that you're going to be giving people. Exercise, weight control are really important for improving outcomes. So now your colon cancer patient. She's a 65-year-old, otherwise healthy, has had adjuvant chemotherapy, surgery and adjuvant chemotherapy for Duke C colon cancer. Duke C means that the lymph nodes were involved. And she wants to know what happens next. How often do I need to see the doctor? Do I need to go to the oncologist or my primary care practitioner? What kind of regular tests do I need? What problems should concern me? So colon cancer is a little bit different from breast cancer. If for early stage, 90% of individuals early being stages 1 or 2 will be 5-year survivors. For stage 3, 65% will be long-term survivors. 90% of recurrences will be in the first 5 years. So unlike breast, where you do have to be vigilant even to 10 years, for colon cancer, the recurrences are likely to be within the first 5 years. The most common sites are liver and lung. Again, local recurrences in issues and intra-abdominal. And just like breast cancer, an important risk factor for a new colon cancer is a previous colon cancer. So matricinous new primary cancers can occur to 3 to 5% in the first 5 years. Now, also, unlike breast cancer, studies have shown that there is a value in detecting recurrence early. So there have been meta-analyses of randomized controlled trials that show that a more intensive surveillance regimen with imaging for metastatic disease and testing with a tumor marker CEA can detect recurrence early, because in this situation it is possible to remove the recurrence if it's in the liver or the lung. So I think that that's an important thing to remember that makes breast and colon cancer different. So consequently, the guidelines from the American Society of Clinical Oncology, similar thing with respect to frequency of visits. They're recommending the CEA testing, which is the tumor marker, to be done every 3 months for the first 3 years, and then up until 5 years. And this is only for individuals who are eligible for surgery to remove a metastases if it's detected. If the individual would not want to consider surgery or is not eligible because of comorbidities, then there's no value in detecting the recurrence early. Other blood work with liver function tests, fecal blood testing, it's not blood work obviously, and blood counts are not recommended. Imaging for metastatic disease is recommending. Again, the same rationale behind it is that earlier detection of recurrence. It can be resected surgically, so there is a survival benefit in doing that. Colonoscopy, this is important because a lot of people, poor patients, are subjected to colonoscopies, every year, every 6 months. Colonoscopy recommendations, it should be done perioperatively, and if it wasn't, then it should be done as soon after the operation as possible. Then if it is normal, if it is clear, then at the 3rd year, and then after 5 years. If polyps are detected, then it's a different frequency, but if no polyps are detected, that's the frequency of recommendation for colonoscopy. So now what about general medical and preventive health care issues? So I want to highlight a few points. First of all, over 80% of individuals with a diagnosis of cancer are elderly. So they're going to be 60, 65 years or older. In addition to being elderly, the majority of them have a number of comorbid conditions. So as we're moving away from thinking about cancer survival and to thinking about cancer survivorship, we have to recognize that most of the patients in our practice, particularly with breast and colorectal cancer, will not have a recurrence of their cancer, and so attention to their other comorbid conditions is paramount. Not only are there a range of other comorbidities, but often those comorbidities are quite severe and require quite a bit of attention. So for general medical and preventive care, management of the comorbid conditions almost sort of rises to the surface as the individual has gone beyond their initial treatment and is moving into the well follow-up period, heart disease and diabetes. Early diagnosis of other chronic conditions is still valuable because you still want to introduce as many secondary preventive measures as possible for those other chronic conditions. And preventive healthcare, screening for other primary cancers. And these are the things that we're expert at. These are our expertise. Managing chronic conditions, screening for other chronic conditions are where our expertise are, and those are the things that are essential for cancer survivors. But unfortunately, primary care practitioners and oncologists alike are really not meeting the standard in terms of screening for other forms of cancer. So this is from a study that I did in Canada, but I know that the results in the United States are very similar. And what this summarizes for you is the extent to which breast cancer survivors, so these are the breast cancer patients, those who are Hodgkin's lymphoma, these are long-term survivors, those with endometrial cancer, colorectal cancer. To what extent are they screened for other cancer types? And these numbers indicate never screened over a 5-year period. So they're quite shocking in that somewhere between 50%, obviously the numbers vary, are never screened. The other thing that really makes this shocking, I guess I don't have it, I have a slide later on, that shows you the incredibly large number of encounters with the healthcare system that these survivors have. They're seeing their primary care physicians, they're seeing multiple different oncologists, and yet screening for other cancers is certainly being neglected. So the cancer survivors are at risk of late complications. There are complex interaction between the late effects of their treatment and other medical conditions and their cancer. And there needs to be a new focus on medical care for conditions other than the index cancer, because general health maintenance is vital for these individuals who will be long-term survivors. So now I'm going to quickly look at what is the role of the primary care practitioner in the care of cancer survivors, and a word about survivorship care plans. So this is the slide that I was referring to earlier. It is the case that cancer survivors have a large number of encounters with the healthcare system. So again, this is data from Canada, but it does parallel what we see in the United States. The vast majority of individuals are seeing, this goes up to 5 years after diagnosis, are seeing a combination of primary care practitioners and oncologists. And really a substantial proportion, particularly in the early years, are seeing a primary care practitioner and multiple different oncologists. So these are individuals with a large number of encounters with the healthcare system, and this is data from the United States, which really parallels the same message. Most people will see both primary care practitioners and oncologists. Now, over the years, I have done a series of studies looking at the role of primary care practitioners in follow-up care for breast cancer patients. And my hypothesis when I started out on this body of work was that the primary care practitioner could provide follow-up care, given the definition that I gave you earlier, which was equivalent to oncologist care. And we did a range of studies over the years to test that hypothesis, starting out with more qualitative work and survey work, and then moving on to randomized controlled trials. And I'm just going to give you a flavor of the results of those studies. So with respect to the first randomized controlled trial, which was conducted in England, that was looking at a system of follow-up care that was provided exclusively by the patient's own primary care practitioner versus the oncology care that they had been receiving previously. What we found, our primary outcome was delay in diagnosing recurrence. Was the recurrence going to be missed or take longer to be diagnosed, and then seen again in the oncology system. And you can see here that there was no difference in delay in diagnosing recurrence between the two groups. At the same time, those who were followed by their primary care practitioner had spent more time with that practitioner talking about breast cancer-related issues. The costs for the patient were substantially less, and the costs for the healthcare system were less. At the same time, the patients had quality of life, including anxiety and depression, were equivalent, but patient satisfaction was higher for those followed by their primary care practitioner. We then went on to do a larger study. That one I just described to you had about 300 patients in it. And had about 1.5 years of follow-up. And we then went on to do a larger phase 3 study, which had almost 1,000 patients and 5 years of follow-up. And this is the study design. Essentially, women with breast cancer, 1 year after diagnosis, had completed their primary treatment, were randomized to their own primary care practitioner, so not a specially trained primary care practitioner, whoever was their own primary care practitioner, or continued in the cancer center as per usual practice. For the primary care practitioners, we sent them a 1-page guideline. This is an example of the guideline of what to do during follow-up. And our main outcome was the rate of serious clinical events associated with recurrence that are potentially preventable. So those would be pathological fractures, spinal cord compression, hypercalcemia. And you can see here that those events, first of all, were extremely rare. So this is the first study that actually documented how frequently those events are, and that they occurred with equal frequency in both groups, regardless of who was primarily responsible for follow-up care. Again, this is a graph of quality of life from the SF-36, a standardized measure of quality of life, and for the medical component and physical component scores, as well as all the subscale scores, which I'm not showing you here, they were equivalent. Anxiety and depression were the same, and again, patient satisfaction was higher. So based on that work, where there were 2 randomized controlled trials that really showed that primary care practitioners could provide follow-up care to their breast cancer patients, which was the equivalent to oncology care, and that's based on 2 guidelines. We then went on to do a third trial. It's called, we consider it the phase 4 of the study, looking at survivorship care plans. Now, for those of you who have been following the literature on survivorship, you will know that one of the things that's being recommended, and was recommended strongly in the IOM report, is that all patients should receive a survivorship care plan, which is essentially a treatment summary, as well as recommendations for follow-up care, other healthcare related things and signs and symptoms to look out for. So the overall objective of this study, this final study, was to determine if a survivorship care plan and an educational intervention for breast cancer survivors ready for transition from specialist care to primary care improved patient or health service outcomes. So here is the graphic from the IOM report and their recommendation that every patient should receive a survivorship care plan, which includes the various elements that I've just summarized for you before. So we conducted a multi-center randomized controlled trial involving 400 patients on active treatment through oncology centers. And the patients in the control group, so all patients, were transferred to their own primary care practitioner for exclusive follow-up. And all patients had a final, what we called a discharge visit with the oncologist, which was a visit where the oncologist said, you're now going to be transferred for your primary care doc is now in charge. If you have any problems, come back and see me. And at that visit, the oncologist sent a letter to the primary care doc saying the same thing. So both groups received that. The intervention group got the full survivorship care plan, which included a 30-minute session with an educational session with a nurse, plus the full survivorship care plan. And the patient's primary care practitioner, family physician, this was in the Canadian healthcare system where primary care practitioners are family physicians predominantly. All these documents were sent to the family physician. So here are the various documents, treatment summary, what to look out for in terms of signs and symptoms, some specific questions and answers, a summary table of visits, frequency of visits and tests, as well as a recommendation about local supportive care resources. So following from this, so as a result of this study, our major outcomes were our whole range of different patient-reported outcomes related to continuity of care, satisfaction with care, psychological adjustment in general, to breast cancer specifically. And from these graphs, these are change scores from baseline over time. You could see that there were no difference between the 2 groups, those who received the intensive survivorship care plan versus those who received that one final discharge visit with their oncologist. So that study, I was just at the NCI yesterday talking about the results of the study, and the study really, I tell people it's a negative trial with a good news message. And the good news message is that, you know, we don't necessarily, for all patients, we don't necessarily have to give them that full package, which is actually has substantial resource implications to it, as long as there is a clear final visit with the oncologist that indicates what's going to happen both for the patient and for the primary care practitioner. So the 2 guidelines, the American Society of Clinical Oncology guideline and the Canadian guidelines, both say that the primary care practitioner can be responsible for exclusive follow-up care for breast cancer patients. And in survey work that we have done, we've seen that actually the majority of primary care practitioners are willing to do that. They are willing to take on exclusive responsibility for follow-up care, 50% within under 2 years, and certainly 90% beyond 3 to 5 years. And the request is that there be certain support tools to help with that. patient-specific standardized level for guidelines, printed guidelines, expeditedly referral, and the ability to have a quick telephone consultation. So with supportive tools, the majority of primary care practitioners are willing to take on exclusive follow-up care. So in conclusion, there is a growing prevalence of cancer survivors in our communities. There's a change in perspective from looking at it as a life-threatening disease to looking at it as a chronic disease. There's a growing body of research that shows that primary care practitioners can, are, and wish to play a role in post-treatment cancer care. For breast cancer patients, a standard discharge visit with the oncologist seemed to achieve similar results as a survivorship care plan and educational session. Quality of general preventive care is a concern for this patient population, so we need to change our perspective in considering these things. And the involvement of primary care practitioners in post-treatment cancer care is essential, but guidelines are needed as well as access and education. So thank you very much, and I'm happy to take any questions. I didn't get my exercise, did I?
I have a question. You went very
I thought everybody was rushing to ask me questions, but I see they're rushing to get after lunch.
My question is about the survivorship toolkit. It looked like you had already done a lot of that work. Is that available? You went very quickly through the slides.